This is Mary, the NICU translator, and today we're going to talk all about neonatal jaundice, also known as hyperbilirubinemia. Quite the mouthful. It's a super common diagnosis that happens both in NICU babies and term babies alike. So let's dive into the what, the why, and how it's treated. So jaundice is a diagnosis that occurs in about 60% of term infants and up to 80% of preterm infants. And it ranges in severity from just something that we monitor to something that can be life-threatening and really serious. So first things first, what is neonatal jaundice? It's also known as hyperbilirubinemia, which means that there's too much bilirubin in the blood. Bilirubin is what happens when the body breaks down red blood cells. This can be a normal part of red cell development, but in babies, they sometimes have too many red blood cells, which can cause too much bilirubin in their blood. So in order to understand what happens in babies with jaundice, it's helpful to understand just normally what happens in a body when the body needs to break down extra red blood cells. When the red blood cells are broken down, they turn into a form of bilirubin called unconjugated bili, or sometimes indirect bili. This type of bilirubin is fat soluble and circulates throughout the blood until it gets to the baby's liver. In the liver, it's broken down into conjugated bilirubin, also known as direct bili, and that type of bilirubin is water soluble, which means that it can pass out of the baby's body in its pee and poop. In normal circumstances, in you and I also, this happens all the time, and the body just is able to keep up with how much bilirubin is in the blood and pass it out, and nothing bad happens. What happens in babies with jaundice is that the body cannot keep up with how much bilirubin is forming in the baby's blood, that unconjugated bilirubin. Because the bilirubin is fat soluble, it can pass over into the blood-brain barrier, which means it can cross over into the baby's nervous system and can cause serious long-term damage and possibly even death. This is super, super rare now because we monitor bilirubin levels extremely closely and intervene when we think that it's rising inappropriately. So you might be wondering why some babies get jaundice and other babies don't. There's a lot of different risk factors for jaundice in babies, especially those that cause you to have extra red blood cells in your blood. So this can happen just in a normal delivery. The baby gets an extra whoosh of blood from the placenta and from the cord when they're born, and they have what's called a higher hematocrit. So they just have extra red blood cells that they needed while they were in mom, and they don't need anymore. So those need to get broken down. Sometimes it also can happen if the liver isn't working as well as it should, which can be related to an infection in the baby or prematurity, where the baby's organs are premature and just not working at the same level as they were before. They also could be linked to what's called maternal blood type incompatibility, so RH or ABO incompatibility. Basically, the blood type of the baby does not match with the blood type of the mom, and the mom's red blood cells and antibodies recognize the baby as foreign and start to break down the baby's red blood cells even before they are born. Those babies are at especially high risk of jaundice, so you might, if you have certain blood types, you might have been checked to see if the baby has your blood type right at delivery, and if they don't, then they would be monitored extra closely to make sure that that does not happen. The other reason is that some born is really hard and they get kind of bumps and bruises as they come out. So those bruises are where the blood vessels kind of break a little bit and the red blood cells come out. So that's just extra red blood cells again that the body needs to break down. So if your baby has some extra bruising or some molding, a cephaled hematoma on their noggin, they might be at higher risk for jaundice as well. In addition to things that happen during and before birth, another risk factor for jaundice is just poor feeding. So one of the ways that the body flushes out that water-soluble bilirubin once the liver converts it is the urine. And in order to make urine, you need to have a lot of extra fluid, and the fluid in a baby comes from feeding. So if your baby isn't feeding really well, or they're super sleepy, which can happen also with preterm infants, they might not be making as much urine or passing that first poop, which is called meconium, and that also can kind of cause that bilirubin to get backed up in the blood and need intervention. So how do we monitor bilirubin levels? How do we know if they're getting too high? Every baby born in the hospital will have a TC bili, or transcutaneous bili, done while they're in the mother baby or postpartum unit. That's just a little light that shines either on their forehead or their chest, and it gives a basic number of where the bilirubin is on a particular moment. It's then plotted on a curve, so it depends on how old the baby is and how many hours old and how old they were at birth, so what their gestational age was, and that will give the provider a risk factor for developing pathological jaundice, which would need to be treated. It also, if the fat level is high, may need to be checked with a serum bili, which is gotten from a little heel stick, so a few drops of blood in a container that's sent down to the lab, and it gives a much more precise number of what the baby's bilirubin is. Just of note, bilirubin peaks at about day of life 3 for term infants and on day 5 or 6 for preterm infants. So if it's starting to rise a little bit, the provider might need to monitor even closer. In the NICU, it might be just frequently for a couple of days. If your baby is term and goes home, it could be some extra visits to the pediatrician just to make sure that things are not rising too quickly. So what happens if you find out from your baby's provider that too high bilirubin and they have hyperbilirubinemia or jaundice? It sounds kind of scary, but the treatment is really simple, which is called phototherapy. So you might have seen this like bright blue light that shines above the baby. Sometimes they lay on a blanket that's blue, and it's a special light that is able to convert the baby's bilirubin into that water-soluble conjugated form so they can pee and poop it out. Essentially, it's helping the liver. It's like a second liver doing that extra job. Expose as much skin as possible because the light shines on the little capillaries, so the tiny blood vessels in a baby's body that's closest to the surface of the skin. The light shines on the blood vessels, breaks down the bilirubin into the conjugated form so they can pee and poop it out. This is why it's super important to expose as much skin as possible when the baby is under phototherapy. So they'll be in their diaper, they'll have little goggles to help protect their eyes from the blue light. It's not super dangerous, but a lot of risk over a long period of time can cause a little bit of eye irritation. So they'll be in their diaper with the light above, maybe below, and just kind of hang out there and let the lights do their magic. The more skin exposed, the more capillaries, which means that the more bilirubin can be converted, and the numbers should drop as quickly as we need them to. If your baby's levels continue to rise despite phototherapy, the next step would be something called an exchange transfusion. This is super rare because we are really good at monitoring bilirubin levels and intervening before they're too high. But if it does get to this point, then what happens is the baby's blood is removed through an umbilical line, kind of where the baby's belly button is, and replaced with donor blood at the same time. So that blood that is filled with the high bilirubin from broken red blood cells is replaced with fresh donor blood, which does not have that high bilirubin level. And after that, usually the baby doesn't need much more intervention and they can just kind of move on and go on to the next phase of their little baby life. If you have any questions about bilirubin or phototherapy, leave them in the comments below. Also check out my Instagram page at the NICU Translator. I have lots of other information about NICU care and tips and tricks for new nurses and new NICU families. So thank you, and see you next video.